Welcome to this meeting on CNS case presentation. So today's presentation will be chaired by Dr. Safwan Ahmed, Associate Professor in Department of Neurology in Father Muller Medical College, Mangalore. Sir has done his MBBS from Kasturba Medical College, Mangalore, and MD from Mysore Medical College, and DM in Neurology from NIMANS, Bangalore. Sir's special interest and field of expertise ranges from cognitive neuroscience to neuromuscular disorders and autoimmune neurology. So, with your permission, can we start the presentation, sir?
Yes. You can start.
Thank you, sir.
Sure.
Yes, sir. Good evening, everyone. The case presentation for today is of a 65-year-old female patient with a cerebrovascular accident.
It sounds better if you tell 65-year-old lady.
Lady, yes, sir.
Than tell female patient.
So we have a patient, a 65-year-old female patient named Shanti Amma, who hails from RT Nagar and is a housewife by occupation. Her education is done from 10th standard and she's married. She's right-handed and is from the low middle socioeconomic status as per the Kupaswamy socioeconomic scale. She came to us with chief complaints of deviations of face to the right side since 3 days, weakness of the left side since 3 days, and slurring of speech since 3 days. She's a known case of type 2 diabetes mellitus and hypertension since 12 years. She developed deviation of the face in the evening after her walk around 6 p.m., after which she had drooling of saliva from the left side. She complains that it felt like food was stuck under the left cheek, but she could close her eyes. On further questioning for the weakness of the left side, she could not walk on the time of the sudden onset of the attack, but her left lower limb could not move and she was able to walk with instability after. She could not raise her leg to walk at the same time. Her upper limb could not be raised above her head, she could not comb her hair, and she wasn't able to touch her nose with the same hand. She also complains that she had difficulty in turning sides. On the questioning for the slurring of speech, it was gradual in onset along with the facial deviation. The slurring of speech could not be understood fully by her daughter. She can now speak normally. Apart from this, on further questioning, there is no history of alteration of smell, diplopia, squint, nystagmus, syntosis, abnormal of sensations over the face, difficulty chewing food, nasal regurgitation, nasal tone of voice, vertigo, hyperacusis, tinnitus, or hearing difficulty. There is also no history of loss of sensation over the left side during the onset of weakness. There's no history of worsening of symptoms or incoordination in the dark or the sensation of electric shock while flexing the neck. There was also no history of urinary or rectal incontinence at the time of weakness. She also complains of no swaying of side to side and tremors or no history of fever at the same time. In the past, she complained of blurring of vision with excessive lacrimation 1 week ago, which lasted for about 15 to 20 minutes. There was no history of headache at the same time. There was no history of fall around the same time or convulsions. She's on oral hypoglycemic agents and antihypertensive medications since the last 12 years, and she's not adherent to medications. There's no history of similar complaints in the family and no history of stroke in the family as well. She's a non-vegetarian by diet with reduced sleep since this attack of weakness. Her bladder and bowel movements have been regular. There's no history of substance abuse or consumption of alcohol or tobacco. Summary: a 65-year-old female patient with history suggestive of a transient ischemic attack 1 week ago now presented with deviation of the face to the right side, left-sided weakness and slurring of speech since 3 days. On admission, she started weakness of her lower leg, which suggests dense hemiplegia of the left side. So, would you like me to proceed to the examination part?
No. Akshay,
Yes.
can you go back to the first slide?
Yes, sir.
Hello? Yeah. So, Akshay, see, when you tell chief complaint, you have told deviation of face to the right side since 3 days, weakness of left side means left upper and lower limb, and slurring of speech since 3 days. So
Yes,
you
sir.
have to add, was it acute in onset, sudden in onset?
Yes, sir. It was, sir, it was
Sorry,
sudden
acute in
in
onset or
onset.
chronic in onset?
Yes, sir.
Sudden onset weakness of left side and sudden. All right, we'll go to the next slide. Okay, now here the first line. You known case of diabetes and hypertension should be mentioned in the past history and not in the HOPI. He has come with those three complaints. So you will strictly speak only about those complaints and nothing else. Okay,
Yes, sir.
and all negative history will be relevant only to those chief complaints. That's it, nothing
Yes,
else.
sir.
Okay,
Yes, sir.
so you cannot tell known people start. It's like summarizing. Known case of diabetes and hypertension
Yes, sir.
history. That should come in the summary and not here. Okay.
Understood. Yes, sir.
So when you start, can you elaborate on this developed deviation of face in the evening after walk around 6 p.m. Drooling of saliva from the left side, foot stuck under the left cheek, but can close the right. Can you elaborate on this? Can you tell me what exactly does this mean to you?
Sir, to me, it means that so in the evening, when she came after her walk, she developed a sudden deviation of the face to
What
the.
was she doing that time? She
She
stopped.
just came back. Yes, sir. She was on her way back from home, and all of a sudden, near her house gate, she started feeling the deviation of the face to the right side.
She
So,
felt it.
yeah, she felt it. Like she could feel like, okay, there's something happening on the face. At the same time, her daughter noticed it, and
So it was
yes,
sudden in onset.
yes, sir.
It was sudden in onset, no?
Yes, sir.
Okay. Sudden in onset facial deviation. And deviation was to which side?
Towards the right side, sir.
Towards the right side. That has to be mentioned, no?
Yes,
So
sir.
initially she noticed that suddenly that her face is deviated to the right side. Correct?
Yes, sir.
Okay. And then drooling of saliva from the left side. Immediately.
No, sir. Like this. So this is when she started feeling like food could be stuck over the her left cheek. That's when she started feeling it. So it took about
So at 6 p.m. when she had sudden onset drooling of sudden onset deviation and she started eating.
yeah. No, sir. She could feel like the cheek was tight on the left side, sir.
No, right? What did she do after that? This is history.
Yes,
Sorry?
sir.
Tell. So
Yes,
what
sir.
did she do after that?
So after that, immediately what happened was she could feel like her legs weren't able to move, like her left limb. She was unable to walk further from there. She felt like she wasn't
What
able.
was happening?
She felt as though her left-sided body was getting weak. She started talking to her daughter at the same time.
What was the time
So around 6 p.m. in the evening.
gap between the deviation of the face, left lower? No,
Time
6
period.
p.m. You first told me, see, that is very important.
Yes, sir.
Okay. Now, we all know what is the case and what case you are presenting. We started with that. It's a stroke case
Yes,
which you are presenting.
yes, sir.
Okay. So, in a case, suddenly, one is stroke, the other one is trauma. Okay. So, it should be a stroke, correct?
Yes, sir.
So, it's
Yes,
a
sir.
vascular event. Now, you'll have to tell exactly the sequence of event. Now, that will help you in diagnosing what type of stroke is it.
Yes, sir.
Okay, just telling stroke is not enough. You'll have to tell is it ischemic stroke, is it hemorrhagic stroke. In ischemic stroke, is it embolic stroke or thrombotic type of stroke.
Yes,
So
sir.
the tempo of event should be very clear. And how long did it take for her deficits to start and peak?
Yes, sir.
That should be very clear, which is not mentioned in your HOPI. Okay,
Yes,
so
sir.
first thing you should mention is sudden onset. That is also not mentioned. Okay, sudden onset, there was deviation of phase to which side, that should be mentioned. And after that, you'll have to tell what exactly did the daughter notice. And then
Yes,
when she continued to walk, when she noticed this facial deviation and she continued to walk, and then she developed left side weakness, left lower limb weakness, she was not able to move, right?
Yes, sir.
She's not able to move. So you should ask her, why was she not able to move? What did she feel? Did she feel like the leg was very heavy? So when there is suddenly weakness, no, they feel as if that is the leg has become like a log, able to lift it. It feels as if it is some 50 kg weight is put on their leg. That suggests it suddenly onset when they feel the heaviness of leg. No, that is what they feel in stroke.
Yes,
So you specifically ask what exactly happened. Okay.
yes, sir. Understood,
She
sir.
could not raise her leg to walk means what? Raise her leg. They don't raise her leg in walking. They lift the leg.
Yes, sir.
Okay. They lift the leg to clear the foot off the ground. So was she not able to do only that? That means it is only the distal weakness, not the proximal weakness. Or was she not able to move at all? That should be very clear.
Yes, sir.
Okay. And then you have mentioned the next line, upper limb could not be raised above head.
Yes,
Okay.
sir.
So now she went and tried. Why did she try to raise her head?
So she tried to do that to call for help because she could feel like something was happening, and she tried to call for help.
Now, when something was happening, she would
Yes,
not
sir.
go and comb her hair, no?
No, yes, sir. So this is something that I asked afterwards. Like, okay, around that time, do you think you could have done that? So because
No,
I was
no, no,
yes, sir.
no, no. So that is you cannot presume anything.
Yes, sir.
So you should ask what did she do? Okay, what activity of daily living she tried to do during that time and she was not able to do. What do you use your left hand for? Wearing clothes, buttoning,
Yes, sir.
unbuttoning, okay, or carry something. So was she able to do during that time or not able to do? Could not comb her hair. Nobody when they have stroke they'll not go and comb their hair.
Yes, sir.
And why was she doing? Why was she going to touch her nose? It doesn't make any sense.
Yes, sir. I understood, sir. Yes, sir. So these were the questions that I asked in a retrospective
These
sense.
are
So
leading questions. So
yes,
you
sir.
should not ask leading question. You should ask what is. She will tell that if you ask her were you able to touch her nose, obviously it's because it was weak. She won't be able to. So those
Yes,
are
sir.
all present. No presuming stuff. So whatever she has told, you'll have to just replicate it in the history. Nothing
Yes, sir.
else. Okay.
Yes, sir.
And then
Thank you, sir.
she had so exactly the sequence of events should be told properly. From the facial deviation to the leg weakness first, you're telling leg weakness first, correct?
Yes, sir.
And then the upper limb. Was it simultaneous or was there a gap of some time? That you should be very clear.
Okay, sir.
Okay. And then initially she was not able to lift her leg only to clear off the ground. How long did it take for her to be completely weak? Or did it become completely weak or it was only partially weak?
So it was partially weak, and
That
then
also is very important.
yes, sir. Yes, sir.
So it was hemiparesis.
Yes, sir.
Because I saw that in one of the lines you had mentioned it as dense hemiplegia.
Yes, sir.
So was it partially weak or was it completely weak? If it is partially weak,
Yes, sir.
what are the moves she was not able to do? Was she not able to hold or was she able to grip and not lift it? All that is very important if it is partially weak. Okay?
Yes, sir.
If it is partially weak, you need to specifically ask what are all activities she was doing in her left knee which she was not able to do. Okay?
Yes, sir.
Do not ask any leading question like touching her nose, combing her hair. No. You should ask what did she do during that time.
Okay, sir.
And then the next line says difficulty in turning side. So she went and lie down in the bed. How did she go and lie down in the bed? Did she
Yes, sir.
need help?
So this was at the time of admission, sir. So this is what she complained of on admission, like she had difficulty in turning sides.
You should
But the
exactly 3 days, no? So you should
yes,
tell
sir.
the 3 days history. What
Yes, sir.
exactly happened? This what happened from 6 p.m. for the next 3 days. She has presented to you with this 3 days history. So that entire 3 days history, you can hear me?
Yes, sir, I can hear you, sir.
Yes. Okay, so this is grossly inadequate history. With this, you cannot make a diagnosis of what type of stroke is it. Because
Yes,
you
sir.
mentioned sudden onset, sudden any. Okay.
Yes,
So
sir.
this slurring of speech, difficulty in turning sides and so on. When did she have difficulty? That night when she went and lied down, she was not able to turn sides.
Yes, sir.
Okay. So difficulty in turning sides happens only when there is dense weakness. Okay, when there is dense weakness involving the trunk. So when there is truncal weakness, that is when they're not able to turn. Otherwise, if it is partial hemiparesis, they'll be able to turn. Okay.
Yes, sir.
So this history again, you should ask: when did she find it? That night or the next night?
The same night or oh, yes, sir. I'll ask this, sir. Because she just
That you know exactly onset. All right. And its slurring of speech is gradual onset. So whenever there is a facial deviation, and then you told there was a pooling of saliva from the left side, obviously her speech would be clear. So it is not gradual onset. So she would have tried to call for help. She would have tried to talk. So then it is also correct.
Yes, sir.
So it is not gradual onset. So gradual onset is a slowly progressive. Okay, gradual onset we tell for something subacute and chronic onset. So this is all sudden onset, slurring of speech. Okay.
Yes, sir.
And then she can speak normally now. Now means when? After you saw her?
Yes, sir. When we examined her right now, on admission, she couldn't. She still had slurring of speech, and when we spoke to her today, that's when she had normal
That comes
speech.
in the course in the hospital, not HOPI.
Okay, sir.
HOPI is strictly the history of presenting illness. Why did she present to the hospital? That's it.
Yes, sir.
Am I clear? So the mistakes in these slides are: the first slide should be a part of past history. Okay, you should clearly mention the onset and the tempo of progression of all the neurological deficits. Should clearly mention what happened to the slide, the weakness, which started first leg or upper arm, and then when did it progress to complete weakness or partial weakness, and what was the correlation with the activities of daily life. Okay,
Yes, sir.
you can go to the next slide. Okay, you asked so many negative history. Can I ask why did you ask for most of alteration of skull?
So, because I
Can be
wanted
of
to,
any relevance to you in this case?
in this case,
No, right?
correct, sir. Yes,
Why
sir.
would it be important to you?
So in this case, I was trying to see if there's a
Diplopia? Double
diplopia.
which is double vision. So diplopia
Okay.
would be relevant to you? Yes or no?
Yes, sir.
Why?
So because in this case, she is a known hypertensive. So at the time, we still don't. We can't make a diagnosis as to what type of a stroke it
No, in
was.
this case. These are all
In
negative history. No, why did you say? Sorry?
So she's a hypertensive patient.
Mm-hmm.
So in that case, I wanted to rule out if it could be a hemorrhagic stroke, sir.
Hemorrhagic strokes will cause double vision.
No, sir. But
Why double vision?
so for looking for the involvement of the cranial nerves as well.
What? So where? What type? What involvement of which part of the brain will cause cranial nerve involvement?
So the frontal, the anterior part of aspect of the brain.
Cranial nerve is already involved. No, the facial deviation.
Yes, sir.
No, see, double vision means brainstem involved. So in case of brainstem strokes, you can have double vision. Okay,
Yes, sir.
either in the midbrain or in the pons. So this is for brainstem strokes. But in this case, you should tell double vision. Squint, she won't be able to tell. It is someone else who tells. Nystagmus is an examination finder.
Yes, sir.
Ptosis is grouping of eyelid. Never mentioned technical terms in the history. Okay. Again,
Yes, sir.
abnormal sensation over the face will suggest what? Where do you get this abnormal stroke?
Normal sensation over the face.
Why did you ask this? I'm not the one who asked. You only
Yes,
asked
sir.
this.
Yes, sir.
Why did you ask all this? You
So
should have something in your mind before asking, no?
yes, sir. So I want what the way I proceeded to ask this sort of negative history was to see if there were cranial nerve involvements. So I did not know much further from that.
Why cranial nerve? So which part of, that's exactly why I'm asking.
The brainstem, sir. Yes, sir. Yes, sir.
So cranial nerve, this is just for brainstem strokes. Okay.
Yes, sir.
So abnormal sensations over the face, which will happen in which type of brainstem stroke? Involvement of which part? Any other MD students are there? They also can answer. Srihari, maybe you can call out if you know anyone of any of the. Okay, that's all.
I think
So abnormal sensation of
students
the over
can
the face.
type in messages on chat. I think that will be okay. I think Dr. Chaitanya,
Right.
voice is not clear and lot of disturbances. Okay. So, sir, would you repeat the question
So
again?
specifically abnormal sensations over the face, which will happen in which type of stroke? Involvement of where? No, he has asked so many negatives. I just wanted to know why did he ask. So abnormal sensations over the face can happen in the brainstem stroke again. So in pontine involvement or in the lateral medullary stroke. Okay. Abnormal sensation of one half of the body can happen in posterior limb of internal capsule, thalamic strokes, or in pontine strokes. Okay, that is entire face and body will go, but only this only in the face can happen in pontine or in the lateral medullary. Okay, and difficulty in chewing food. See, chewing food is something a function of trigeminal nerve, the muscles of mastication. So that does not happen in strokes. Okay, there is swallowing difficulty, nasal regurgitation and nasal tone of breath. That is in brainstem stroke. Again in the medullary stroke. Okay, vertigo, hyperacusis, tinnitus can happen in medullary. Okay, you should know all this. Why did
Yes,
you ask all this? And no issue of loss of sensation over the left side of the during the onset of weakness. So you're mentioning this. No issue of worsening of symptoms. You're only contradicting. So there was worsening of symptoms over one day, no?
yes,
So
sir.
initially it was only the face, and then it involved the limb, and then it became complete weakness, and then there was recovery also. In coordination in the dark. So these are all irrelevant history. Please do not ask all this.
Yes, sir.
Okay, this is not. This negative history should be strictly related to the stroke and nothing else. So, for the cause of the stroke.
Yes, sir.
No history of urinary or rectal incontinence at the time of onset of the weakness. No history of swaying to the side. She was not able to walk well enough. Forget about swaying to the side.
Yes, sir. So, sir, she has at the time of weakness, she was able to walk with not able to raise her foot above the ground. She could walk with some sort of instability. After which, when she was shifted to the hospital, it became a bit more worse, and then
So why did
gradually
you
started.
ask no history of swaying to side to side? What
I
in a
asked
case?
I asked, was she, while limping, did she feel like did she feel like
I mean, what was in your mind when you asked no history of swaying side to side?
so the vestibulocochlear nerve?
For vertigo.
Yes, sir, for vertigo.
Vertigo for ataxia for vertigo, vestibular ataxia.
Yes, sir.
In the case of stroke, which type of stroke will have side to side swaying?
So that's
Cerebellar stroke, no?
yes, sir.
Cerebellar stroke can have swaying to either side. Why did you ask about tremors?
So again, for this is in case of cerebellar, sir, the tremor part.
Tremors do you get?
Sir, I'd like to interrupt for a second. Are you able to see the chat, sir? Because a lot of postgraduate students are replying on the chat. As I can see here, Dr. Vishak has replied that it is cerebellar stroke. So,
Yeah,
good effort, Dr. Vishak. But can you see that, sir? I think.
I can see.
Right. Okay. Yes.
Tremors? The point I'm trying to make is don't ask
Yes.
negative history, each and everything, whatever is there in the textbook. No. Or whatever you know. You should ask
Yes.
relevant history. Okay?
Yes, sir.
If you ask no history of fever, how is it relevant in this case? If there
So,
was a history of fever 1 week back and he has come with this, what would you think?
so
Or if there is a history of fever and then she gets this, then what do you think?
maybe an embolic stroke, sir, in case of fever.
What is stroke fever?
I was thinking in case of,
Stroke is embolic straight away.
no, sir, not straight away, sir. Possibly.
Any of the medicine students? If there was active fever and then she has the stroke, what would you think? Fever, rash, and stroke. I'll give you another one. Fever, rash, and stroke.
Fever.
She's a lady, middle-aged lady. Middle-aged, no? What is her age?
65 years, sir.
Elderly lady. Elderly lady. So, which type of infections can cause stroke? Short history with rash. Okay, varicella can cause. Varicella can cause vasculitis and stroke. Herpes can cause herpes can cause stroke. Okay, so all those are involvement vessel involved. What you meant was the meningitis will have severe headache. Okay, I'm talking
Yes,
about specifically only vessel involved. So varicella and all need not have anything else, only the vessel involved. I meant what you meant to tell was rheumatic carditis, correct? And
yes, sir.
infective endocarditis. Infective endocarditis will have a prolonged history. Okay. Okay. So now, what are the types of strokes? You know.
So there are two types of strokes: ischemic and hemorrhagic.
There you go. So what is the type? What are the types of ischemic stroke?
Ischemic strokes. Types of ischemic
Rahul, 1 second. Dr. Srihari, how much time do we have?
Sir, we have 1.5 hours totally starting from 7. So I think we have another hour left for discussions. Yes.
Yes, sir. What are the types of ischemic stroke? Types of ischemic stroke.
So thrombotic strokes
There
and embolic, thrombotic, embolic, and
are only two types: thrombotic
yes,
and
sir.
embolic. So what in history do you get in thrombotic type of stroke and embolic type of stroke?
So in thrombotic type of stroke, there should be,
All are sudden onset.
yes,
Okay,
sir.
onset that's sudden. So thrombotic and embolic, how do you differentiate?
Thrombotic and embolic. It'll be sudden in onset in embolic stroke, sir.
All types of
And
stroke will be sudden in
yes,
onset. That's why.
and
What else is the differentiating feature?
early morning will be in cases of thrombotic stroke, sir.
Mm-hmm.
And embolic can happen at any given time of day.
Mm-hmm. So early morning strokes, wake up strokes are usually thrombotic. Agreed. Okay, then.
Then embolic, thrombotic. Then there might, in cases of embolic, so there has to be a way an embolism is developed. So in that case, there can be history suggestive previously of deep vein thrombosis or of palpitations that might be suggestive of
I think
tachycardia.
for deep vein thrombosis, in
Yes,
the
sir.
thrombosis, as you told, is in a vein, no?
Yes, sir.
How will it enter the artery?
So it will traverse from the either from a defect in the heart, that's an atrial septal defect, or if it gets dislodged and it travels within the bloodstream.
Where? From the venous stream, it gets distributed to the arterial stream, and from the leg, it will go all the way to the brain.
No, sir.
Arterial system is
Yes,
away
sir.
from the heart, no?
Yes, sir. So it's in cases of atrial septal defect, sir.
With atrial septal defect with right to left shunt.
Right to left. Yes, sir. Right
Very
to left.
possible. Then what else can cause? Is the most common type.
More common. So,
Will be the PFOs, patent foramen novels, okay, which have right to left shunt.
yes, sir.
PFOs are very rare, what you told. Okay, with the septal defects with right to left shunt, for that the patient should have already pulmonary hypertension. Okay, these are all rare things. All right, tell. Then
Yes, sir.
that is not one of the reasons. See, embolic stroke do happen suddenly as other strokes. But the onset to peak to develop neurological deficits is very short. It happens in seconds to minutes. So in minutes, there is peak deficit. Like there will be mild weakness suddenly to begin with, and within a minute there will be complete weakness. Okay,
Yes, sir.
so very short, within seconds to minutes, onset to peak happens in embolic. And embolic strokes usually happen during any point of exertion, like walking or like walking during time of exercise. Okay, it doesn't happen in overnight in the night.
Yes, sir.
So very short onset to peak, and then during exertion, which happens. Okay, and even the symptom resolution, the symptoms improving will be much more faster in embolic type of strokes.
Yes, sir.
So rapid onset, rapid progression, and rapid resolution. So this happens in embolic type of stroke. Okay, whereas thrombotic, it's usually very slow. Sudden it starts, but then there is stepwise progression. So the onset to peak takes about few hours. Okay, can progress up to 24 hours.
Yes, sir.
Okay, so patient has come with facial deviation, then develops a mild weakness on the left upper and lower limb. Over next few hours, up to 24 hours, it can progress to complete weakness. Then you know that it is a slowly forming thrombus, slowly occluding the vessels. So those are thrombotic type of strokes. Okay,
Yes, sir.
clear?
Clear, sir. Yes, sir.
Rapid progression and rapid early resolution in embolic. Sudden onset, but slow progression and slow improvement happens in thrombotic type of stroke.
Yes, sir.
Now, how do you differentiate between hemorrhagic stroke? So, hemorrhagic stroke also happens at the peak of exertion. Okay, they'll be usually during an emotional outburst or during the time of exercise when there is sudden rise in blood pressure. Okay, they will have preceding to the deficit. They'll have severe headache. So there will be severe headache. They'll have a symptom, and then the downhill, the onset to progression will be very rapid. It's a bleed. No, bleed continuously expands until you control the blood pressure. The sensorium will go down. Okay,
Yes, sir.
the rapid onset and progression of symptoms. Headache at peak of exertion, severe headache followed by deficit, rapid progression, and decrease in sensory. Okay, these are the
Yes.
hemorrhagic. This is hemorrhagic type of stroke. Clear?
Yes, sir.
How do you differentiate? So your history becomes very important. How you mention. Okay.
Yes, sir.
Go to next slide. So this past history of type 2 diabetes and hypertension should come here. Okay. Now this
Yes,
history
sir.
of blurring vision with excessive lacrimation. What does it mean to you? When there is excessive lacrimation, no? So lacrimation covers the cornea also. That also can cause blurring of vision. What is this? You should elaborate more on blurring of vision.
Yes,
What
sir.
is it? There was tunneling of vision. There was like amaurosis fugax. There was sudden curtain-like sensation which came from up to down and then had visual field effect and then rapidly improved. What exactly happened? Now, no TIA will cause excessive lacrimation. Okay,
Yes, sir.
lacrimation is a peripheral function, not a central function. So, what is this history of blurring of vision? What exactly happened?
So in this case, like I was trying to get some sort of history of case of I was trying to probe for it, like TIA
Again,
as
leading question. You
leading
cannot,
questions. Yes, sir. That mistake.
you cannot presume everything is related to that stroke.
Yes, sir.
Okay, this might have been something dust should have gone inside the eye. That also can cause lacrimation and blurring of vision, and then within 15 minutes it can be all right. Don't
Yes,
presume
sir.
it is a TIA. For TIA, it is always localizing. Okay, So in
Yes,
the
sir.
case of TIA involving visual symptom like blurring of vision, it should be in the ophthalmic artery. So ophthalmic artery is a branch of internal carotid artery.
Yes,
Okay.
sir.
So in that case, ophthalmic artery supplies the retina. The superior and inferior is divided into two. So they'll have clear curtain-like sensation involving one of the eyes. Okay. So they'll have a visual field defect,
Yes,
either
sir.
upper or lower or both, which is not there. So that is the clear involvement of a TIA, not here. Okay. Sudden onset, rapid progression, and rapid resolution. It will not involve lacrimation. Okay, this may be some small foreign body was there inside the eye. I do not know. So do not presume that as a TIA.
Yes, sir.
And no history of headache, fall, or convulsion should come in HOPI, not here. Okay.
Yes,
How
sir.
a past history of 1 month back, fall, convulsion, fall, or headache, how is it relevant to you?
So in case of the headache, I was thinking hemorrhagic stroke. Like, so if she would have had some
No.
sort of headache.
Again, I'll ask you. It could be possible. Okay, past history. 1 month back, she had a fall and then developed headache, and now suddenly she developed weakness. What could that be?
Dislodgement of the dis.
Anyone else can answer. No problem.
Yes, sir.
MDPTs also. 1 month back fall. She's an elderly individual. She might have fallen somewhere and then developed headache, and then suddenly developed one side weakness. So what could that be? Anyone? She could have had a fall and developed subdural. Okay. So there is the time period. So there is a lucid interval. No, there can be all right for about 2 to 3 weeks, and then slowly that blood can increase, can become subacute to chronic, and when it increases, suddenly the level of death. Okay.
Yes, sir.
How is convulsions relevant in your history? All this convulsion should come in HOPI.
Yes,
How
sir.
is convulsion relevant in your history? Fine,
Same.
she had a convulsion, say she about 10 minutes back, she had a convulsion and then she noticed this right side weakness. What would that mean to you?
Headache and convulsion. So that could be in cases of
No, convulsion. She had a
encephalitis.
convulsion.
Yes, sir.
She had a
Maybe.
convulsion.
Yes,
And then
sir.
she developed that same side weakness. She had a left focal convulsion lasting for about 3 to 5 minutes. And then after that convulsion stopped, she noticed that there is weakness in the left side. What does that mean to you?
Have you heard about the term called
Oh.
Todd's paralysis?
Yes, sir.
Okay, so that starts paralysis. It's in the post-ictal state. Okay, it's a post-ictal state. So that they develop immediately after the seizure and then rapidly improve. Okay, within 24 hours they improve. Thought paralysis doesn't last beyond 24 hours. Clear?
Yes, sir.
Go to the next slide. Rahul, how many neurology cases have you presented till now?
So this is my first case, sir, actually.
Okay. No
Yes,
problem.
sir.
Family history, no history of similar complaints. Similar complaint means no history of stroke in the family.
Yes, sir. So I was trying to rule out the hereditary
You would have
causes.
to draw at least 2 generations of pedigree chart in family history. Okay.
Yes, sir.
Medicine graduates, please learn to draw pedigree chart.
Yes, sir.
So any examiner can come and ask what are the different symbols mean to you. Okay. Next, in case of stroke, it is very important. Any vascular events like MI, any history, any patient had any major vascular events can have a stroke also. Okay, so you should ask not only about stroke, you should ask about any major vascular event. They could have had any peripheral vascular disease or an MI. Okay. Next. Okay. Next. 65-year-old lady, it is not history suggestive of TI. Okay, do not mention that.
Yes, sir.
65-year-old lady presented with sudden onset of weakness of left upper and lower limb along with facial deviation to the right side. okay, of 3-day duration. Okay, I would like to think of a stroke. Correct, sir. Now tell me, in a diagnosis, there are always 4 components. The neurological deficits. For that deficit, neurological deficit, the anatomical localization. The
Yes, sir.
third is the pathology, and the fourth one is the etiology. So these 4 components should be there in the diagnosis at the end of history and at the end of examination. Now tell me, what are the neurological deficits she had? She had left UMN facial paresis, correct?
Yes, sir. Yes, sir.
And hemiparesis. So the same side weakness. And the hemiparesis, one side sudden onset, and then left UMN facial paresis. So
Yes,
it's a
sir.
UMN type of weakness, correct? So for this, what is your anatomical localization for one-sided weakness? So where and all can it be? This stroke.
So it can be at the cortical level because it's an upper motor neuron lesion.
The cortical where?
Cortical in the place of the motor neuron. Cortical. It can be in the premotor area, sir, because
Sorry,
in the
what motor
premotor
area?
areas.
Premotor cortex.
Yes, sir.
So specifically involving both the hand and leg motor cortex, the entire premotor cortex. There is no particular vessel which supplies only the premotor area. Okay, so for it to involve the hemiparesis, the entire left hemisphere should have gone, which is a large infarct. That would have caused a severe depression in sensorium also. Okay,
Yes.
for it to cause so much dense hemiplegia, without intact sensorium is very unusual. Okay, so in this case, because she had preserved sensorium throughout, so it's likely to be a small stroke only, but it is a subcortical. For the small stroke to cause such dense weakness should be in the subcortical area, not in the cortical area.
Yes, sir.
Okay. Okay. So in the subcortical area, which are the area which can cause left hemiplegia?
So internal capsule for subcortical.
What is above internal capsule?
Sir?
What is above internal capsule?
Above internal capsule, we have the.
Who is medicine postgraduate in this? Vishak Srivastava? Dr. Gulfam. So what are the localizations? Can you tell? Corticobulbar. Corticobulbar fibers where? So corticobulbar fibers pass through which area? Okay, so you should always start from the subcortical area. So from cortex to subcortex, there are first is centrum semioval.
Yes, sir.
Okay, the centrum semioval, and then below that it goes down to the corona radiata. From corona radiata to internal capsule. Okay, so
Yes,
internal capsule has the anterior limb, genu, and the posterior limb. The corticospinal tract, most of the corticospinal tract pass through the posterior limb. Genu will have corticobulbar fibers, and the facial fibers predominantly will be there in the anterior limb. Okay, and even in the posterior part of the corona radiata and posterior part of the centrum semioval. Anywhere infarct can cause a dense hemiparesis or hemiplegia. Okay, after the internal capsule, it comes down below to thalamus. So ventral anterior thalamus is a motor part. Okay, ventral anterior thalamic infarct can cause a dense hemiparesis. From thalamus, it will come down to the midbrain. So midbrain, the anterior part is the crus cerebri. So the crus cerebri involvement can have left hemiparesis. From crus cerebri, it will come to the pons. From pons, it will come to the medulla. At medulla, at the pyramid, it will cross over. Okay, so in fact, anywhere on this side, in the upper medulla, in the right pons, or in the right crus cerebri, right thalamus, anterior thalamus, right ventral anterior thalamus, right corona radiata, right centrum semioval, or right internal capsule can cause left hemiparesis, along with left UMN facial paresis. Except for below the pons, then it will be right element facial paresis and left hemiparesis. Okay, it will be crossed weakness.
Yes, sir.
Okay. So do not restrict yourself only to the internal capsule. So you are beyond MBBS. Okay.
Yes, sir.
All right. So that is the anatomical localization. And what is the possible pathology? So we do not know exact progression. So I'm presuming that she progressed over 1 day. So I think that it is thrombotic. She was walking, and then while walking, she got it. It could be embolic. So I do not know what is the progression. If she has progressed within few minutes, then it is likely to be embolic. If
Yes,
she
sir.
has progressed over 1 day, then it could be thrombotic. Okay. And the
Yeah.
etiology is again the hypertension and the atherosclerosis because of hypertension and.
So, for
Go to
this
the next
patient,
slide.
yes, sir. She was diagnosed as thromboembolic stroke, sir.
From where? Thrombus from where?
So she has
Okay. That is an examination. You have not seen any of the investigation. You're not
yes,
supposed
sir.
to.
Correct, sir. Yes, sir.
Exactly why I told that. For
No,
that, you should know the progression. Here, I'm not.
yes, sir.
She was walking, so she was exerting. So if she has onset to peak in few minutes to less than an hour, so it is likely to be embolic.
Yes,
But
sir.
if she has progressed over 1 day, then it is unlikely to be embolic. It is likely to be thrombotic. Okay, if it is stepwise progression. Stepwise progression is always thrombotic, not embolic. Okay.
Yes,
In
sir.
case of embolic, continuous shower of emboli from one of the thrombus, it will be like one deficit that will improve. There will be, and then another deficit will come that will worsen.
Yes, sir.
A continuous shower of emboli. That's the different scenario. Okay. We can go to the examination.
So,
What is
general,
the relevant history for this in general physical examination for you?
sir.
What are the relevant general physical examination findings in case of stroke?
In
What is
case of
supposed
stroke.
to be?
Yes, sir. So the patient's BMI, the pulse rate,
Very good.
blood pressure.
BMI, then pulse rate.
Yes, sir.
How is it relevant to your pulse rate?
So pulse rate, it can tell us if the patient is into atrial fibrillation. So if that's the thing, the etiology.
That is the regularity of the pulse rate. Okay, then.
Yes, sir. Then blood pressure is an indication for hypertension, so that can lead into hemorrhagic stroke, sir, from there.
Okay, then.
Then if the patient is overweight,
Character of vessel wall. If
character vessel.
it is atherosclerosis, it is thickened.
Yes, sir.
Then what else?
So and then after that,
What are the signs of dyslipidemia?
signs of dyslipidemia. So xanthomas over the eye. Um, the patient is obese, and one more would be xanthomas, overweight, and yes, sir, xanthomas and the patient's overweight.
Okay, all right. Okay, you can go to the next slide.
So on systemic
Yes,
examination.
cardiovascular system and the GP, respiratory system we mentioned there. Go back.
So
Go back. Respiratory rate. Okay, next.
yes, sir. Yes, sir. On central systemic examination of the central nervous system, higher mental functions were intact, where the patient was well oriented to time, place, and person with good attention. She is conscious and cooperative. Her speech is normal, and her mother tongue is Kannada.
Why is mother tongue Kannada in systemic examination?
So, because if we have to check for speech aphasia and any sort of speech abnormalities, it would be best tested in the mother
Yes.
tongue of the patient.
What is the mother tongue should be told in first slide.
First, okay. Yes, sir. Yes, sir.
Speech is normal. There is no dysarthria.
Yes, sir.
Facial weakness, facial currency that improved by the time you went.
Yes, sir. So her speech had improved by the time she was admitted to the hospital. So she was able to
There
give
was no facial deviation.
facial deviation. It's still there, sir. But
The facial deviation of speech was normal. There was no
yes,
dysarthria. What are the components of speech? There are two components of speech. One is articulation and one is language.
yes, sir.
Okay. So if there is facial deviation, there is likely to have labral dysarthria.
Yes, sir.
Because this thing is supplied by the facial nerve. Correct? If there is posterior circulation involving the tongue, then it is likely to be lingual dysarthria. And the 10th nerve involvement, if it is there, it will cause guttural dysarthria. Okay, these are the articulation difficulties in speech. Okay, so you should tell about articulation, the language, the phonation, anything is speech difficulty. So
Yes,
if
sir.
there is dysarthria also, you are supposed to mention it. Okay, there may not be any language deficit, but then the dysarthria would have been there. Next slide.
Yes, sir. Cranial nerve examination. Examining
For anosmia,
for anosmia. So I've taken coffee.
the smell is normal.
Yes,
How did
yes,
you coffee?
coffee beans, and I've taken peppermint in small bottles.
What
And
did you do? Can you tell me?
I asked her to close her eyes. I covered her eyes, and I told her to identify the odorant by covering
Both
her
the,
eyes and covering one
both the
nostril.
nostrils.
And once she covered the nostril, and I asked her to smell the odorant and identify what she could smell.
If you was not, if she would have told, this is very familiar, but I'm not able to tell what is this, then what does that mean?
So
Anosmia.
that not anosmia, so parosmia.
Parosmia.
Sorry, not parosmia, sir. Sorry. She's not able to make out.
She is not able to identify it. So if they are able to smell, that is
Yes,
enough.
Okay,
Okay.
yes, sir.
If you give something, if you give coffee and then tell it is pungent smell, she cannot tolerate it, then it is parosmia. But if
Okay,
she is
sir.
able to smell it, then it is normal. Okay, it is not anosmia or hyposmia. It is normal. Most of the men will not be able to remember the smell. Okay, if
Yes,
you give
sir.
them smoke also, they may not remember the smell because that is
Yes, sir.
of least interest to them. Okay, so do not think it is anosmia. All right. Olfactory hallucinations, parosmia. Don't mention all this. Okay, you tell olfactory is normal. That's it. Do not
Yes, sir.
mention negative and all in examination kind of. No, nothing. Trigeminal motor, normal. Okay, no
Yes,
deviation.
sir.
It is understood when you tell normal that it is normal.
Yes, sir.
Okay, optic normal fundus not examined. What about field?
Field of not written field of vision. It was within normal. Yes, sir.
So you did field by doing what method did you use? Check
So
middle field.
the finger test, sir. I asked the patient to close one of her eyes,
Not
and
finger test. This by visual field by
yes, sir.
confrontation. Okay?
Yes, sir.
Confrontation method.
Yes, sir.
With that, she was able to sit. She's a stroke patient. Now, how did you make her sit?
So no, sir. From the while she was lying down, I've tested
You did confrontation by lying down.
like this. Yes, sir.
One confrontation.
Not, sir. Yes, sir.
So if you have not done, you have not done. Okay.
Yes, sir.
The examiner is smart enough to tell what you have not done and what you have done.
Yes, sir.
Okay. Fine. Next move. So no bluffing. So if you have not done something, you have not. Okay, never bluff. Oculomotor, trochlear, everything is normal. Go to facial. Facial is wrinkling of face, closes eye tightly, angle of mouth deviated to the right side with prominent measurable fluid, no hyperintensity. Wrinkling of face, closes eye tightly, angle of mouth deviated to the right side. So there is left facial paresis, likely to be human facial paresis. Correct, no?
Yes,
What
sir.
the lower half of the upper end, the lower half of the face is more involved. Why does only facial nerve get involved in this case in UMN?
Human only
And no
facial.
other criminal nerves got involved.
So
Why
because the center of motor center for the facial nerve, it supplies bilaterally. The genu, because the genu is where it supplies also.
Sorry?
The genu of the facial nerves
What supplies? Genu of the facial nerves?
is supplied by the same blood supply for the internal capsule.
Same side.
Same side, yes, sir.
So what about other cranial nerves?
They are supplied by uh, by the posterior vascular system, sir.
You should get your concepts right. So all the other cranial nerves have bilateral innervation. Okay, so if one side goes, the other side compensates for it. Whereas the facial side has only opposite side innervation. Okay, not from the same side. Understood? That's why in the case of stroke, only facial nerve gets involved because it gets innervation only from the opposite side, not from the same side. But other cranial nerves have bilateral representation. Okay? Did you
Yes.
understand? Continue.
Yes, sir. On facial nerve examination, there was a wrinkling of face. The patient closed her eye tightly, and angle of mouth is deviated to the right. With
No, you
prominent.
continue. Next.
Oh, yes, sir. On motor examination, sir, there is no wasting. On the right-hand side of the slide, I've placed the bulk
There's
measure.
hypotonia.
Yes, sir.
Hypotonia. From grade 5 on
Yes,
right side and 0. That's hemiplegia. So it was hemiparesis to start with, and then she had hemiplegia. So I was
Yes,
asking, partial hemiparesis or it is complete? It was complete.
yes, sir.
But it is hemiplegia. Okay. The bulk is same, the superficial reflex, deep tendon reflexes, all are absent. Okay. Next. So there's hypotonia, dense weakness. Why is it hypotonia?
Hypotonia.
Women, no? So women
Yes, sir.
usually have
Placid.
why is this flaccid weakness? Next slide. You can read,
yes, sir.
Rahul. Okay. Sensation is perfectly. So it's pure motor. Next.
Yes, sir.
Romberg sign not examined. Why?
So the patient is not able to stand. So,
Very good.
yes, I
CNS
could.
posterior column examination. What is the posterior column with in the spinal cord?
Yes, sir.
What is column mean? And why have you done no cerebellar signs in that posterior column? Spinocerebellar.
Yes, sir.
Do not have these headings, okay?
Yes, sir. Yes, sir.
So if you have done cerebellar sign, if you thought of a cerebellar stroke, then you mention cerebellar signs in a separate column. Otherwise, do not mention all this.
Yes, sir.
Autonomic nervous system within normal limits. What did you do? Test for autonomic nervous system.
So,
Where did you get this template from?
so this template I got it from a book, sir. The book's name is. Can I go and get the book, sir? The name to.
Which book is this? American.
No, sir. No, sir. It's an examination book. It's from Kerala, sir.
Meghalaya.
Yes, sir.
I think this is just for your basic understanding. Do not follow
Okay.
Hutch. Okay?
Yes, sir.
Do not follow any other book.
Yes, sir.
Follow some standard books.
Yes, sir.
If you are interested in neurology, then go through. Well, it's a very small book. Go through bigger stuff. Okay, so it's a very good book for all medicine postgraduates. Please go through. There is the Indian version of bigger stuff by Ravi Yadav and Kameshwar Prasad.
Yes, sir.
Very good book. If you read it once or twice, that is more than enough.
Thank you, sir.
Okay. Yeah. So do not mention all this. Okay.
Yes, sir.
You're just digging your own grave by putting all this in the examination. Next, go to the next slide. So nothing. See, this thing
Yes,
is
sir.
normal.
Business not move.
Next.
Yes, sir. So, provisional diagnosis of this patient. This is a cerebral.
Finish the examination. So here's the final diagnosis.
Oh,
You're done with the examination. No, any other part of examination is left.
So the investigations for the patient.
That's okay. See, you're supposed to make a provisional diagnosis after history, final diagnosis after examination. Okay?
Yes, sir.
Don't mention provisional diagnosis, some this thing and all. Just mention diagnosis after history, diagnosis after complete examination. Next, go back, go to the next slide. So it is a diagnosis,
Yes, sir.
not a provisional diagnosis, it is a diagnosis. Diagnosis, you should first mention neurological deficit. So it is left human facial paresis and then left hemiplegia.
Left human.
Neurological anatomical localization, you have to mention. Right middle cerebral arteries, right MCH supplies a large territory. It supplies you 2/3 of the brain. So entire 2/3 is gone.
No, sir. Not. No.
Like to your examination, cardiovascular.
Examination. Yes, sir.
No, next slide. Next slide. Next. Yeah, what is S1, S2 word? No number. Really? You're telling me she is in F1, AF?
Yes. So
AF, what will happen?
irregular heartbeats would be there, sir. And
Then
there would be an increased heart rate and for the patient.
decreased heart rate, right?
Increased heart rate, sir.
Why? Increased heart rate in AF, atrial
Because
fibrillation.
there are.
In atrial fibrillation, what happens is atria will be fibrillating.
Yes, sir.
Only maybe out of 10 fibrillation, one will get transmitted to the ventricle and then ventricle will contract. Okay. So when ventricle contracts only, you'll get the pulse. You'll not get pulse otherwise. So
Yes,
doesn't mean that if atria is fibrillating at 200 also, only 50 will get transmitted. So doesn't mean that all AF will have very high heart rate. Okay.
Yes,
So tell irregular heartbeat was there. Then what else do you find in AF? 65-year-old AF.
so
What
then,
else?
because
In case it is RHD, did you get any murmurs? No murmurs. What happens to the intensity of heart sounds?
increased, and gets increased.
It was increased. Okay, JVP 7 centimeter.
Yes, sir.
It is normal.
Yes, sir.
Next slide. That is grossly inadequate diagnosis. Okay.
Yes, sir.
Diagnosis, again, first thing should be neurological deficits. Anatomical localization could be left internal capsule, right internal capsule. Okay, the posterior limb of internal capsule. Posterior tip is sensory. Posterior limb is motor. Genu is corticobulbar, and anterior limb contains most of the facial fibers. Okay.
Yes, sir.
So right coronary data, it could be right internal capsule, it could be right centrum semioval, or it could be right crus cerebri. It could be anywhere. The midbrain crus cerebri is in a midbrain. Usually when there is crus cerebri midbrain involvement, there is associated involvement of third nerve, which is not there in this case. So we can always keep it as above midbrain. So it could be thalamus also. So enter the anterior nucleus of thalamus. It could be 4 Ds. Localization could be anywhere. Okay. So
Yes.
it is a subcortical structure, so it is likely to be a small vessel stroke, not a large vessel stroke. All small vessel strokes are penetrating branches, not a large. The large stroke would have had a lot of other symptoms. Like in left MCA involvement, will have aphasia. No? So what will happen in the right MCA involvement? The cortical involvement, left cortical
Yes, sir.
involvement will have language deficits.
Language
What
deficiency,
will
sir.
happen in the right cortical involvement?
The right cortical
What we can expect in the right
consciousness would be
the large
patient
involvement. Okay, that will happen in the left cortical. Specific, what are the functions of right cortex?
altered sensorium. Consciousness will be decreased.
It's a large impact. No, I'm telling you, cortex is it. Left cortex involvement is in speech area
Language.
in the left cortex. Right
Yes, sir.
cortex, what will it call?
Right cortex.
So do not mention it in the right MCA, okay? Right MCA
Yes, sir.
is a big one. Okay.
Yes, sir.
So this is likely to be an internal capsule, coronary data centrum semioval is supplied by the M1. Okay, the lenticular striate branches of the M1. So you should specifically mention that. Okay,
Yes, sir.
and in etiology, it's likely to be either lipohyalurosis or the arteriosclerosis secondary to hypertension.
Yes, sir.
Okay, all right.
Yes.
Rahul, for the MBBS student, you've done decently, but then I think
Sorry, sir. Yes, sir. I just realized.
in your history taking.
Yes,
So
sir.
within more and more, and then I think you will do very well.
Yes, sir. Thank you,
All
sir.
the best for your similar situations.
Thank you, sir. Thank you so much, sir.
Pierre, anything to add?
Nothing else, sir. I think with a little bit of more preparation, it would have been nice. I think it would have been better if PG had presented a case, but it's okay. He has done his efforts, so we have to appreciate his efforts.
Right.
And great job, Dr. Akshay. You've done really well. It's just that minor tweaking and probably a little bit of guidance would have helped a lot before presenting. That's totally
Yes, sir.
all right. I think we can end the session now. Thank you very much, sir, for chairing the session and guiding our fellow postgraduates. And thank you, Dr. Akshay, for presenting. Do you want to add something, Dr. Akshay? If you want to add something, you can add.
You want to
No,
ask
sir. I just
something?
like to thank Dr. Ahmed for all his guidance, even through this. While I was presenting, I know I wasn't the best presenter, and sir
No,
was
that's not good.
teaching, through this. So I'd like to thank sir a lot for, at least, take out his valuable time in teaching right now, all of us.
No problem. Okay, all the best.